Hi, everybody. I'm Dr. Jeremy Pettis, and I'm joined, as always, by my good friend,
Dr. Steve Edelman.
And this is the Taking Control of Your Diabetes podcast. So today's episode is going to be on what we're calling the science of type 1 diabetes. Really what's going on in the world of type 1 diabetes research, what's exciting in preventing and kind of the cure realm, if you will, with type 1 diabetes. Steve?
Yeah, and there's a lot going on in this field, and it's actually extremely exciting. So, Jeremy, why did I get type 1?
Well, we will get to that. So I think, like we were talking about earlier, like, why are we talking about this? Well, Steve and I were both diagnosed with type 1 when we were 15, and we're talking about when we were both diagnosed, we were told that there would be a cure in 10, 15 years. And I don't care if you talk to a person with type 1 diabetes that is 5 or 95, they'll tell you the same thing. There's a cure that's kind of like right around the corner. It always seems like it's just been there, but yet nothing is happening. And we're here today to tell you that there actually is stuff happening.
All right, to start off, one of the early comments I have for you is, when do you think there'll be a cure for type 1?
I would say probably 10 to 15 years.
You're full of crap, just like the rest of those doctors that told me that.
I think we're getting there. But I also made the comment that, we used to end our type 1 conferences at TCOID, the big like in-person conferences, with this kind of like what was on the horizon talk. And I kind of felt like I was really digging deep to think of topics. And honestly, it left the day kind of a bummer because there just wasn't a lot of hope. And we're going to get into some things that like are potentially going to be approved in the next, weeks to months from when we're recording this. And if you're listening to it later, some of these things might actually be approved. So things are happening really here and now.
Yeah, and I really think we're on the cusp of coming up with a disease-modifying therapy, not just treating high blood sugars.
Yeah. And a little history on that, people say, why did like always 10 to 15 years? Well, we discovered back in the 70s really that type 1 was an autoimmune disease. And so once we discovered like a little bit about what was causing it, it was just kind of a natural thinking that we'll have a cure kind of right around the corner. And there are some specific things about type 1 diabetes that delay the progress. I mean, you look at other autoimmune diseases, rheumatoid arthritis, inflammatory bowel disease, even multiple sclerosis. There's all these new therapies. So it's natural to wonder, where are the therapies for type 1? And we'll get into the pathophysiology, but type 1, it's really difficult to study and it's difficult to treat for a couple key reasons. Number one, beta cells don't grow back. So once you lose our beta cells, Steve and I, I'm looking at deep into Steve's eyes here, and we just don't have beta cells. And, I wish they could grow back, but they don't.
You pass the tissues, please.
Yeah. So that means you only really get one shot at trying to save them. It's not like an inflammatory bowel disease, for example, where you're constantly kind of regenerating your cells in your colon or whatever, and you kind of have multiple opportunities to try to treat it. Beta cells, they die, they don't come back. And the other thing is the pancreas is really, really hard to investigate. These cells are buried within the pancreas. You can't really biopsy them. You can't image them. So even if you have a therapy, it's hard to know what the heck's going on in the pancreas. And so there are some reasons. It's not that investigators have been sitting on their hands for decades. It's a difficult disease to study.
Yeah, and from my perspective, and you have a much deeper background in immunology than I do, is that, the immune system is incredibly sophisticated, complicated, always changing. And the immune system that you're going to explain in a few minutes that attacked our beta cells when we were 15, it's still in our bodies. So you can't just say, I'll take a transplant, I'll take some islet cells and go home and you're cured, because that same immune system that we have would attack it and destroy it. So
right.
That's been the big pushback.
So that, what is type 1 diabetes? So let's talk about that. Well, we know, I mentioned it's an autoimmune disease, and that means that your immune system, Steve was just talking about, goes awry, and it attacks and destroys the beta cells of your pancreas. And it really is a specific surgical attack on this one cell type. The islet cells, or the islets in the pancreas, are these small little, another word for islet is actually island. It's these little islands in the pancreas that contain the beta cells. And right next to the beta cells, there's cells like the alpha cells that make glucagon. We all know what glucagon is. It raises our blood sugar. There's delta cells. There's epsilon cells that do different hormones. And it's just these beta cells that the immune system doesn't like for some reason. And there's lots of theories about why that is. But ultimately, it thinks it's something bad.
I look at the glass half full picture. Thank goodness it's very specific. Just think if it was a immune attack of our entire pancreas, or the heart, or the liver. But it's amazing, this one very specific cell that produces insulin and this other hormone called amylin. But Jeremy, do we know why the immune system goes awry?
No, we don't. Like full stop, we don't. There's lots of theories, and I'm a big believer in that it's probably different triggers for different people. I think if we were looking for the trigger that set off this autoimmune thing, we probably would have found it by now. People have blamed viruses, specifically these Coxsackie viruses that people get hand, foot, and mouth disease. There's a part of that virus, a part of the amino acid structure that looks very similar to proteins made in the beta cells. So people hypothesize, well, if the immune system recognizes this as a virus and the beta cell is just slightly different, it makes sense that it could kind of jump over to the beta cell. And people blame vitamin D and things that are going on with breast milk and early gluten, and nothing's really kind of panned out. The stat that I mentioned earlier is that if you have type 1 diabetes and you have an identical twin, there's about a 50% chance that that identical twin will get type 1 diabetes. So I like to use that as a rough estimate to say, well, clearly there's a genetic component. You have an identical twin, you have essentially the same genes. But if it was just genes, then it would be a 100% chance that the other twin would get it. In this case, it's 50%. So there's something else going on in the environment. And again, identical twins, they tend to grow up together and do all the same stuff together. So what is triggering one and not the other? We just don't know.
Yeah. It's interesting how type 1 is so sporadic. As you mentioned before, most type 1s do not have someone in their family with type 1. Type 2s is completely different. 80% of people with type 2 have a family member. So, it's fun comparing and contrasting them. We're not going to do that during the whole show today, but they are two completely different conditions.
Mm-hmm. So the other thing that is really pertinent to our discussion today is actually not just talking about, what type 1 diabetes is from an autoimmune perspective, but when type 1 diabetes, quote unquote, starts. So we all think of I got type 1, I went into DK when I was 15 and you were 15. Truth be told, we had type 1 very likely for years before that. This autoimmune process starts years. We could have been 9, 10, 11, 12, who knows? We didn't really check our antibodies. And we're realizing that now as a community that type 1 starts long before the symptoms occur.
Yeah, and I think that's a good point because we didn't have the test to measure the antibodies back then. We didn't even know what the antibodies were. Nowadays, we can measure antibodies, we'll get to that, and identify people long before they present with type 1, which creates an opportunity to intervene.
Totally. And so the process usually is that this immune system gets triggered. And it's almost this one by one destruction of the beta cells. And I'm making this little hand gesture that Steve likes, but you guys can't see. A little killing hand.
Looks like you're milking a cow.
Yeah, but
I'm
killing beta cells. I'm kind of squishing them.
Well, you have that one video too.
Yeah. But you can actually see these beta cells getting destroyed in kind of real time. And this process happens very slowly over time, over years. And it's not till you get down to about 20% of your beta cells that are left, meaning 80% of them are dead, that you go into DKA or get, high blood sugars. So people will usually say, well, they could associate in their head when they got type 1, something that happened. I don't know about you, but right before I got type 1, I had a really bad flu. And I remember thinking for the longest time that flu gave me type 1 diabetes.
I thought you went to Chili's first.
I went to Chili's. It was the baby back ribs that but I had the flu. Those ribs were delicious. I still go back there. I don't have any bad memories of Chili's. I love Chili's.
Okay.
But anyways, people will think, there was that trigger, or, pregnancy is another one, or a car accident, or some kind of stressor. And what usually happens is that, you've had this autoimmune process going on for years. Your beta cells are kind of hanging on by a final thread, and there's some last stressor. And in my case, it was the flu and some baby back ribs that kind of pushed me over the edge. So it wasn't that final cold or whatever that caused it. It was the final stress. And people love to blame something or find a reason. Oh, I ate, gluten 2 days earlier, and it doesn't work like that. Did you have any trigger?
You know what? It's so important you mentioned that because a lot of people still are fighting in their own minds what caused them to get type 1. And they have crazy theories, and I don't blame them. Some people like to know, but for anybody out there with type 1, as you mentioned, Jeremy, you've had it years before they came down with the visible disease. And we just don't know what causes type 1. And most people who have type 1 do not have a relative with type 1.
Yep.
Just like you and I.
Yep. We're the only ones in our family, the only cool kids. Well, we were talking though, depending on if you call us brothers or not, then we'd be a family. But I guess we're not brothers; we're just friends. So
We're brothers with a different mother. You know that. I've said
So-
that a bunch of times.
here's the good news: we now have ways of measuring these antibodies in the blood that can predict if somebody's going to develop type 1 diabetes, or if this, a better way of saying that is identifying that the immune process of type 1 diabetes has already started. And there's about 4 or 5 of these antibodies that we can test now with almost any lab can test these. These are common antibodies that are available now. And the way this works is when we talk about, before somebody clinically comes down with type 1 diabetes, 3 different stages of, if you want to call it pre-type 1 or early immune activation, that show us the process of the immune system. I'm going to kind of walk through these because it's important when we talk about these stages because it's different places where we can potentially intervene. So the first one we call stage 1. It's a great name. It just tells you what's going on. We kick the names around a lot.
It's the first stage.
Yeah, stage 1. And stage 1 is defined as that you have 2 or more of these antibodies present in the blood. And it's not how much of the antibodies or how high the titers are. Simply once these antibodies become present, at least 2 of them, we know that you essentially have developed autoimmune type 1 diabetes. Your blood sugars are normal at this stage. But at this stage, the chance of you getting type 1 diabetes in the next 5 years is about 50%. And the lifetime risk
is 100%. Right. So it's a critical time. You have no symptoms. You never would have tested unless you were worried about it in the first place. And we can talk about screening later.
Yeah. So we're definitely going to get into your ears are perking up. Well, how do I know if I have these antibodies? We're going to get there. So hang tight. Keep listening. So next after stage 1 is, I forget the name. What is it?
I think it's stage 2.
Stage 2. Yeah, that's actually what it is. So stage 2 is next. And at stage 2, you still have these 2 antibodies, but you also have what we call
dysglycemia.
Mm-hmm. Steve likes that word.
DYS. I love that word because it's kind of a code word for your blood sugars are messed up just a little, but if you did a formal diabetes test, you would come out normal.
Yeah.
So it's already showing some physical signs, but not into florid diabetic ketoacidosis.
Yeah, it's not a code word. It's just the definition.
I like to call it a code word.
Because it sounds cooler that way.
Yeah.
So yeah, you have 2 antibodies, but your blood sugars are a little high. Completely normal otherwise, but your 5-year risk is now 75%. You're getting closer to that, clinical diagnosis of type 1. Stage 3 is then when you've got the antibodies, you've got glucose intolerance, and now you've got some symptoms. So this is really where we would say this is time that people would normally go to the hospital, or it's like they've initially been diagnosed. So those are the 3 stages that I would call pre kind of classic type 1 diabetes. But again, the important concept here is that we're calling all of this type 1. When you're in stage 1, you have type 1 diabetes. And again, that's really so important because it changes our whole mindset. And instead of saying we're intervening at somebody who's at risk, we're saying, no, we're intervening with somebody who has type 1 diabetes because we know their lifetime risk is 100%. And that completely changes the game.
Yeah, you know what? We have these stages. I don't think anybody should be thinking they're distinct stages. Mm-hmm. It's all part of a continuum. But, we need to classify the stage so that we can do proper research and direct certain therapies towards each stage.
Absolutely. All right. So then you got these 3 stages, and then you get type 1. And for a lot of people, that's still DKA. But, we'll get into this too. But an advantage of knowing with testing your antibodies is you can be prepared for this and avoid DKA. But at any rate, you're diagnosed. And when you're diagnosed, you still have about 20% of those beta cells that are left. And those are valuable. Those are worth saving. So a lot of people had a honeymoon period when they were first diagnosed. Did you have a honeymoon?
I had a really bad honeymoon once, but back when I was diagnosed.
We're talking diabetes here.
I don't remember, Jeremy. I really don't. But I think it's important to explain it because everyone hears that.
Yeah,
term.
So I think I had a kind of classic example. So I went into DKA when I was 15. Blood sugars were through the roof. My, A1C was literally off the charts. My blood sugars were over 1,000. Got stabilized in the hospital. I went home, got put on injections. And pretty soon after that, I actually came off of insulin completely. For somewhere between like 6 and 9 months, I was off of insulin completely. And that kind of messes with your head, because you're like, well, do I have diabetes? And sure enough, it kind of quote unquote came back.
It always comes back.
And what's happening in that stage is really important. So when your beta cells get really stressed out, I had that flu. It was the final hurrah. My blood sugars went through the roof. those remaining beta cells get what we call stunned. They have glucose toxicity, and they just stop producing. So they're still there, but they get shut down because of the high blood sugars and all the stress. And then when you treat yourself with insulin and your blood sugars become kind of normal, they can kind of wake back up, if you will, and start making insulin again, which is exactly what happened in my case. But unfortunately, that immune process is still happening. Those cells are still getting destroyed. And eventually I had to go on insulin and, full insulin therapy. So that honeymoon period is just evidence that there's still cells there that are worth saving.
Yeah. And there are pediatricians who will leave their patients on insulin, just like tiny doses, so they don't think they're cured. You were 15, but even a 5 or 6 year old might think, hey, I don't need the insulin anymore. So they actually continue it just so it doesn't mess with their heads. And the other thing too is there was a large protocol, and you're aware of it, where they tried to treat these new onset type 1s with insulin to rest their pancreas based on the same concept that you're just describing. And unfortunately, there was a little bit of positive data, but mostly it did not work.
Right. So, here's a stage where someone's just diagnosed. They've got some cells that are worth saving. And this is when people get really activated. And I was saying, this is when people will come find me as a researcher. What can I do? I was just diagnosed. Or very commonly, my son or daughter or brother, a family member just got type 1. What can I do to preserve these beta cells or cure them or whatever? So there is a lot of trials going on in this area that I would, kind of deem as like preservation of beta cells. Before we were talking about prevention of type 1, if you will. Now we're kind of into the preservation stage. And there's a lot of, clinical trials going on in this area that we'll get into. And then after that stage, so first of all, let me tell how this stage is defined. So how do we know, Steve, if somebody is still making their own insulin?
Yeah, there's a substance that we can measure, a molecule called C-peptide. If you can think of when insulin's produced in the beta cell, it's got a section of it that when you cut it off, we call it C-peptide. Now, naturally, when that insulin is being processed, ready for this, through the Golgi apparatus, through the cytoplasmic membrane and released into the systemic circulation, the C-peptide is released. And it's a very specific marker for what we call endogenously produced insulin. Pancreas or a pancreas transplant or an islet cell that's been transplanted in. And that's how they measure if these systems and therapeutic interventions are working. It's a very specific marker for the body is producing insulin.
Right. And I think if you didn't mention that none of the insulin that we inject contains C-peptide. So you can inject insulin all day long and your C-peptide is not going to show up. It's very specific, like you said, to what your body is doing. So in these kind of like this preservation area, they can test your C-peptide. And the amount of time that somebody will still produce insulin after their diagnosis is very variable. It can be weeks, it can actually be years that people can maintain C-peptide or insulin production. And one of the key variables to that is actually the age that you're diagnosed. That it seems to be that the younger you're diagnosed, the more aggressive the autoimmune attack is. And another reverse way of saying that is the older you're diagnosed is the more kind of smoldering it can be. So if you're diagnosed when you're 2, your insulin production might go to 0 in weeks. If you're diagnosed when you're 52, you might hold on to insulin for 5, 10 years. It's really, really variable.
Yeah, and some physicians think that if you're newly diagnosed, what the best thing you should do is treat yourself aggressively, keep your A1C down, get on a pump or a multiple daily injection. And those people hang on to beta cells longer than someone who gets terrible care, is not into their disease for one reason or another, and their A1C is 10%. And I kind of believe that too, because you mentioned a word called glucose toxicity, and that's a real word. When your blood sugars are high, it poisons the beta cell to secrete less insulin than it actually could. We see that in type 2 diabetes as well.
Mm-hmm. So this preservation period is defined by basically your C-peptide, which is a functional assay of what your beta cells are doing. And if you have any C-peptide production, you should count yourself lucky, because any amount of insulin secretion we know reduces your blood sugars, reduces complication, actually reduces hypoglycemia, because it seems like the alpha cells that make glucagon and beta cells that make insulin, they're still kind of talking to each other.
Yeah.
So if you still have any C-peptide, it's a good thing. What if somebody's listening, they're saying, gosh, I've had type 1 for 30 years. Should I check my C-peptide?
Yeah, I would say yes.
Yeah.
And I was just going to mention, that's a good question, is that our methods to measure C-peptide are much better than 10 years ago. So they're finding people who have had type 1 a long time that they're still able to measure C-peptide.
Yeah.
So, if you're going to, the only time you would probably do it is if you entered into a research trial and they wanted to check your baseline level.
Right. You can ask your clinician just out of curiosity, and they might say no. I had mine checked a while ago, 0.
Really?
Yeah.
I don't want to get disappointed because I've had, even though we both got it at 15, I've had it, I'm 25
Well, every
years
once in a
older
while, I
than you.
swear, there might be a little insulin in there, but nope. Anyways, so this period is, usually classically a couple years after you're diagnosed that you're still in this kind of preservation period. After that, you're long-standing, what we call long-standing type 1, which is anybody that's had type 1 for, I would say, more than 5 or 10 years. Chances are you don't have any beta cells left. And the reason this is all important is you can see that across this continuum of type 1 diabetes, the disease changes. That initially we're talking about, this is an autoimmune disease. We need, drugs or therapies that reduce the autoimmune attack to preserve the beta cells. But then on the very opposite end of the coin, people like you and me, I don't care what autoimmune process is happening right now. I don't have any beta cells, so I need to get some back. I started off by saying we can't grow them back, so we need to find ways to replace them and replace them without the immune system getting them again. And that's what we're going to talk about kind of next. Any comments on that, Steve?
No, I think you said it quite clearly.
Thank you. That was the first time I've silenced the great Steve Edelman. All right, so let's go into prevention specifically in terms of what therapies or what's new and hot. And I want you to kind of take it away here. But let me set the stage again now that we're talking about these stage 1, 2, 3, people that are antibody positive, they're at quote unquote risk for clinical type 1. What's new in this area?
Yeah, actually, this is probably one of the most exciting areas. And just to remind everybody, stage 2 is when your blood sugars may be a little messed up and you have 2 or more autoimmune markers for type 1 diabetes. And it's a anti-CD3 monoclonal antibody called teplizumab.
You sound really smart when you say that.
Yeah, I know. I just love it. I wish I had a British accent too. It'd be really impressive. And this approach has been studied for 20 plus years. And the company that's now taken over the compound called Prevention Bio, they have teplizumab, and they've done a very interesting study called the TN10. And you're going to go over those a little bit, but it's a drug, and I appreciate the fact that you explain it better than I do, but it basically slows down the immune attack. And they have very impressive results. They already went to the FDA, and the FDA panel voted to approve it, but they're on hold now because they just have to show that their formulation of teplizumab is very similar to a formulation that they used in years past where they have some more positive data. So it's going to be, apparently the FDA is going to make a decision in August. They could always delay it. They could always approve it early. All the data is in. And I'm personally optimistic about getting it approved. Both you and I were at the FDA hearing, so we heard the good, the bad, and the ugly. And put it this way, it's probably the single most exciting thing in type 1 diabetes, closest to a reality. Do you agree with that?
I do. I think it's interesting to talk about these FDA panels really quick because people are probably interested in how these
Can we
work.
cuss on this podcast?
Yeah. But in general, correct me if I'm wrong, because I've been in a couple of these now, they tend to invite about 16 kind of outside experts, and they can be anything. Of course, you'll have in this area endocrinologists, but there'll be statisticians or, maybe pharmacokinetic people.
Pediatricians.
And there's always one patient advocate on the panel. And the way it goes is it's a day at the FDA in...
the company shows their data.
Mm-hmm.
Then the government physicians...
This is like an hour presentation.
Yeah.
The company goes first. Here's why we think it's great. FDA goes second. Here's what's maybe not so great about it. Usually they kind of do like the counterpoint.
They present the data in their own analysis, and sometimes it really is different than the sponsor.
Mm-hmm.
That's what they call the company. And I would say at the one we went to with teplizumab, it was amazingly similar. And that's why I'm kind of optimistic that the FDA understands. But you're going to.
Company goes, FDA goes, and there's an hour of an open public testimony where anyone can talk about why they think this drug should be approved or not. And you were there, kind of talking about some of the positive data. I was there as a testimony of why it should be approved. Anyways, at the end of the day, they simply vote. These 16 people, yes or no. And I don't remember the exact vote on this one. Do you remember?
It was more people yes than no.
Yeah,
but it wasn't like a slam dunk.
Right.
And then the FDA takes their opinion and their vote and everything that came out of the meeting, and they make the final decision a few months later. So they came out and they said, well, we can't make a decision yet until we look at the, what we call, the pharmacotherapy of the teplizumab molecule that Prevention Bio is producing.
Yeah. So it was interesting for me to go through this process of how drugs actually get approved. But let's talk about what teplizumab is, which is an anti-CD3 monoclonal antibody.
I love that accent.
Do you like my British accent? All right. So it is, that's what it is. But basically what it does is it kind of dampers the T cells in terms of lessening their likelihood or activation to attack and destroy the beta cells. I said earlier, it kind of tells them to chill out a little bit and not attack the beta cells.
Well, Jeremy, could you just explain a little bit more to our listeners about the killer T cells?
So the T cells, in order to get activated, there's a couple different molecules that have to bind to certain receptors. And one of those receptors is called, CD3. And if you block that receptor, these T cells can't be activated and they can't go and attack and destroy really anything. So that's the idea. Practically speaking, this is an IV or an intravenously infused medication. And in this clinical trial that we're going to talk about the results next, it was a 14-day course, meaning patients had to come in and get the drug infused. Usually it was a couple hours over 2 weeks. And that was it. It was that one-time kind of intervention. And then the patients were followed for several years. The average time that they were followed was actually for 2 years, but it went up to 7.5 years in certain
Well, it's still going on.
Yeah. So these patients specifically, they're type 1 in the stage 2 that you mentioned. So they were, their 5-year risk is now 75%. And they were what we call randomized 1-to-1. That means they were actually just randomly selected to either get teplizumab, this 14-day course, or a 14-day course of placebo. And I have, some specific numbers here, but what would you say is the take-home result of this trial?
Yeah. Teplizumab delayed the onset of type 1 diabetes by 32 months at the last cut point of the data, 32 months. And that's the mean, which means that some of the people that got teplizumab got a little sooner, but some have not even come down with type 1 diabetes yet. And that's why we use the phrase delay and prevent. Because right now, there are people who took this drug and have not developed type 1 diabetes after 5-6 years.
So, at the last analysis I have, that the percent of people getting type 1 on placebo was 78%. So, almost 80% of the people have gotten type 1 if you didn't do anything. That would be kind of the natural history of type 1. And when they were on this drug, 50% of them had developed type 1 by, the last analysis. So showing that, it's not 100% of people that are protected, but it certainly is showing that it's efficacious. And what do you say when people say, is that really a big deal? Like, how do you put this into context?
Yeah, well...
Besides wanting to punch them.
Yeah, well, I was going to say slap, thinking of the Oscars or whatever. The people who say that really have no clue what type 1 diabetes is. They don't know what it's like to come down with it, to crash and burn, and how your life changes overnight for the parents and everyone in the family. And so that's understandable. To get a 3 to 4 hour infusion for 14 days, that is such a small price to pay to delay type 1 or prevent it for over 2 years. Because I think, look at what we've seen in the last 2 years. We've gone from pumps and the onset of CGM to hybrid closed loop systems and artificial pancreas. Who knows what we're going to see in the next 2 years in terms of therapy? And you mentioned this briefly in the beginning, Jeremy, that anybody involved in any type 1 trial is going to be educated about the signs and symptoms of diabetic ketoacidosis, and those people avoid a traumatic ER visit, hospitalization, ICU, people pricking them, IV lines in, and it's so nice to be prepared for type 1, even if you get it, whether you're in the placebo group or you're in the treatment group and you eventually come down with type 1. So I think it has tremendous benefits.
For me, I think I agree with everything you said, but also just thinking about 3 years in terms of time of a child's development.
Mm-hmm.
That, I think about my, kids, they're 3 and 6. And let's say I knew that the little one at 3 was going to get it. Gosh, what a difference between, 3 and 6 in terms of like mental development and, 3 years of not taking shots and, just getting their head around what type 1 diabetes is. I mean, that time is precious. And, if it was 2 months, I would take it, but 3 years is certainly, a big, big deal.
Well, Jeremy, knowing what you know now, would you screen your kids?
Yeah. So I think, that's what we're going to get into how to do that. I think that is changing. My answer to that question is changing now that we are on the cusp of an approved agent. Because a big, hesitation for a lot of people is, well, gosh, what if I know and there's nothing to do about it? Do I want to know? Do I not want to know? All that. That conversation really changes when it's like, gosh, I can find out, and there's something I can do about it now.
Yeah, my kids do not have type 1. They got tested once over 15 years ago, but at that time, there was nothing you could do, and I was the kind of parent that still wanted to know so I could be prepared. And other parents just say, no, we don't want to get our kids tested. And I respect that 100%.
Yeah.
But now I think things are different. And so there's really coming into a period where we can actually do something about it.
Right. So if you want to get tested, go to type1tested.com. And there's a couple different ways that you can actually do this. JDRF sponsors a program where they'll actually mail you a kit. It's either low cost or no cost, and you can do it at home and, send with a finger prick and kind of send it back in, and they'll give you results. These were positive.
That's amazing.
It really is amazing. And, I would say though, if you do this, you need to be prepared,
to prick your finger.
Yeah. To prick your finger. But if it comes back positive, who are you going to talk to about it? Because a lot of the times, the people that are getting tested, they don't have diabetes. They don't have an endocrinologist, so keeping in mind like what kind of like a plan is. And that's something that we actually need to work out as a society is how are we going to roll out, kind of more uniform screening? Like I said, what if I did get my brother tested and he got the results and he says, well, now I need to get a referral to an endocrinologist. And
yeah, you're right. I never thought of that. Yeah. What happens if you're positive?
Yeah.
It's important that, nowadays, because teplizumab, if for stage 2, no one has any symptoms. And the way they got the individuals to be in this TN10 study was they screened first-degree relatives of type 1. It's kind of like low-hanging fruit. But just for the sake of repeating, most people that get type 1, like you and I, does not run in the family. Mm-hmm. And I'm hoping that someday that's part of if it's inexpensive enough and they can put it in routine testing in kids every couple years just to pick up people early, especially if we have good therapies. We should mention that there's a large study that Prevention Bio just completed with teplizumab for people in stage 3. So newly diagnosed type 1, and that data is forthcoming. So they may have the indication eventually for both stage 2 and stage 3. Now, for stage 3, they're not the minute you get type 1, you're going to be on the lookout for things.
Right.
Instead of emailing and calling
different. You're right. You don't have to be screened.
You've got it.
You've got it. Yeah.
Yeah. And then if you I believe it's, I can't remember how long you have to get enrolled. It has to be early, like 3 months. But don't quote me on that. And then you can find out if you're a candidate for this therapy. And to me, there's no question I would I'd bring my kids in for therapy if they tested positive. Mm-hmm.
All right. So let's leave quote unquote prevention behind and talk a little bit about this preservation category. So you kind of nicely segued there. You just got type 1. You still have some of these beta cells left. Yeah, you might be taking insulin, but it's nice to preserve these beta cells. What's going on in that area? And there really is a ton of research. So first of all, there's a ton of research going on in all these areas. So talking about people I want to slap. It's the people when they say it's, it's a conspiracy theory. They have the cure for diabetes, but they're not telling us. I'm somebody who's actively doing research in diabetes, and I know a lot of people in this field that it would kill to have a cure. So that is just completely false. There's a lot of like dedicated, hardworking people like focusing on all these
people
areas.
really say that?
Yeah, all the time.
I know they do it for type 2.
Yeah. Well, and more type 2 than type 1, but you still will hear it. So anyways, on to other things besides people we want to
Preservation.
Preservation.
Yeah.
So to be in these trials, it's pretty simple. You got to have some insulin production, and meaning you got to be C-peptide positive. And all these trials are designed pretty much the same, that you get randomized to go on some kind of treatment or not, and they just follow you over a period of usually a year or two, and they measure your C-peptide throughout the trial. And the hope is that your C-peptide stays what it was, or ideally gets better, but it's certainly better than placebo. So conceptually, I think people can get their head around that. I just got diagnosed. Here's my amount of insulin production. Here's my C-peptide. Let's see if my therapy can help me preserve that.
Sorry.
So Dompé makes an oral drug. Oral meaning you swallow it, which I'm highlighting because it's obviously easier to take than IV. And the compound there is called latorexin. And the way it works is again, it's an immune kind of deactivator. It specifically blocks this one cytokine called IL-8. And it works more on the neutrophils to hopefully prevent destruction of the beta cells. So a different approach, but the needle to thread with any of these therapies is that you want to slow down the immune system, dampen the immune system, ideally just specifically for the beta cells. But obviously, as we mentioned before, the immune system is very important. And if you get rid of the immune system, you have all kinds of infections, actually cancers, et cetera. So you want to find a therapy that is gentle-ish, that's not going to cause, a lot of side effects, and hopefully get good results. And that's hard to do.
Well, that's why there's a famous slide that Jay Schuyler, a famous type 1 researcher, shows that there have been 300 studies curing type 1 diabetes in laboratory animal models. Rodents, rats, mice. And every time that they had a big press release, type 1 diabetes cured, they try it in humans and it fails. 300. So we're still waiting.
Yeah. I think the number is a lot higher than 300 actually.
That's
now,
all you can fit on the slide. It was hard to see the slide.
So, and that's a good point though, because the things that actually make it into humans are our best guesses, our best hopes. They have obviously animal data that they prevent or reverse type 1 in animals, and they are shown to be safe in humans. So if people are listening right now, they might be thinking, gosh, I just got diagnosed. My son, daughter, brother, whatever. How do I get enrolled in clinical trials? And actually JDRF has a really good kind of like find a clinical trial navigator that you can go online, just type in find a clinical trial JDRF, and it's the first thing that comes up. And I give the actual website, but it's actually kind of long. So the best thing is just to search for it. It comes up and it says match to a clinical trial in 60 seconds. And I actually did this on myself. Hit start, your age, where you live, how far you're willing to travel for a clinical trial, how long you've been diagnosed, some kind of key things. And then in about 60 seconds, it'll pump out some clinical trials that are available in your area. And that's a really good resource.
Yeah, and even though there may be centers further from your home, now since COVID, they're doing a lot of these trials where the individual doesn't have to be at the site more than once or twice a year, and there's usually funds to pay for that. So if you see something that interests you, the other site I think you're going to mention is TrialNet. Mm-hmm. That's a government organization that's kind of a clearinghouse for all the studies in type 1. You and I know the lady who runs it, Carla Birnbaum. And that's another good area to look for clinical trials.
And not to stress people out, and like if you're just diagnosed, but the thing about these trials is when you're diagnosed, the clock really is ticking. That to get enrolled in a clinical trial, you need to kind of act quickly, because a lot of these will have like enrollment criteria that say you have to be within 100 days of diagnosis, or sometimes it's a little bit longer. But if you do want to get involved in a clinical trial, it is something that you should jump on sooner rather than later. Yeah,
and if you know anybody that has a child or come down with type 1, and the more people in the public like yourselves that can spread the word, the better it will be.
And the last thing I'll say about funding a clinical trial is if you are in an area with an academic center, a university, hospital, that's also a good place to just start. Asking the endocrinology team there, if you're endocrinologist, or ask your endocrinologist to ask somebody at the university. These kind of word of mouth things actually work, actually pretty well.
Yeah, if anybody lives in the San Diego area, definitely email TCOYD. We'll get it to Jeremy, and he has a big research lab for type 1 studies with a lot of really good young investigators as well.
Cool. So the last area is what I would call replacement. So we got folks like Steve and I, we got no beta cells.
God, you have to say that.
And we need them.
It's like the fourth time you said it.
Well, I would give mine to you if I had any, but I don't have any. So the idea is we need to get some beta cells back. So it's less about stopping the immune system and more about how do we safely and effectively replace beta cells. And there's a few ways to do that. And I do just want to mention quickly that you can do a whole pancreas transplant. That is an approved therapy. The issues with that is that it's a major surgery. There's a limit on how many pancreases are out there. You have to go through a donor. It's typically reserved for people that need a kidney transplant anyways. So it's not a therapy that we recommend for the masses. Would you agree with that?
I would agree with that. It's, putting the money thing aside, if it worked, it's worth it. But the majority of people that get a whole pancreas transplant, it usually fails. A lot of times they get it when they get a kidney transplant because you have to be on immunosuppressants anyway. Mm-hmm. You have to have a higher dose, and it's very hard to harvest a pancreas because the pancreas has all these digestive enzymes as well as the beta cells. And if you don't get it to the right, laboratory ASAP, it like auto digests.
Yeah.
So I don't think it's a viable approach for the masses.
Yeah.
I agree with you.
And the pancreas is a really kind of like gelatinous organ. It's very different than the liver or the kidney that you can take out very kind of easily. It's very nebulous, and plus it's full of all these digestive enzymes.
Oh,
so
if you held one, it would just go through your fingers.
Yeah.
It's kind of like the glob.
And these digestive enzymes are really toxic. So I've heard a surgeon say that like doing a pancreas transplant is like trying to sew a stick of butter to a leather couch. It's just like gooey and globby, and yet like it's just not easy at all. So anyways, I'll leave you with that visual on pancreas transplants. So moving into other ways to replace beta cells, if we say, okay, pancreas transplants aren't for everybody, what else can we do? Well, keep in mind that we don't need a whole pancreas. Our 99% of our pancreases work fine. The majority of the pancreas is actually just for kind of normal digestion. It's these tiny little beta cells that are much less than 1% of the pancreas. That's all we actually need. So how can we get those back? And there's two main approaches to giving those cells back. You can either infuse them into a vein and they can actually kind of take up residency in the liver, or you can implant them in some kind of device. So first I'll talk about these infusions. And one of the major breakthroughs we're having now is actually in stem cell therapy, that we can generate these beta cells in a lab and keep them alive in perpetuity. So, people hear stem cells, they think we're harvesting these from fetuses and things like that. There's enough stem cells in labs right now to generate, beta cells for every person with diabetes type 1 and 2 on the planet. This is where like stem cells have been really, really remarkable. So you can take those stem cells and actually infuse them into the portal vein of the liver. They can start, living in the liver more or less and responding to glucose and secreting insulin.
Now, you're doing studies with Vertex, correct? And they've had a lot of press lately in the Wall Street Journal. Their first patient did really well. Now there's a hold, but hopefully they'll be able to continue shortly. Their approach is infusion, correct?
They have two approaches. So one is this infusion approach. That's been kind of the first. And then the second is going to be the encapsulation one, which I'll talk about now. So the advantage of the infusion is that it's not a surgery. It's like basically getting an IV and they infuse it. But you still have to take immunosuppressive therapy because these are foreign cells. So the other idea is, well, can we just put these cells in some kind of encapsulated device? Think like a thick credit card or something like that, and implant them under the skin or in the abdomen. And there's several companies working on that, Vertex and ViaCyte. And the advantage there is that you can, contain these cells. And if you design the quote unquote perfect encapsulation device, it would be one that would not let the immune cells in, but would let glucose and insulin kind of freely diffuse throughout the system. So you wouldn't need immunosuppression. And so that's why the encapsulation approach is attractive. And then on top of that, there's another approach, and you were mentioning the CRISPR technology, which is a way of actually modifying these cells to make them, quote unquote, kind of invisible from the immune system. So potentially you could use this CRISPR technology to modify the beta cells, infuse them in the liver, and then the immune system kind of wouldn't be aware that they were there, not need immunosuppression. And then we're getting into like kind of a true cure.
Yeah, that's changing the molecular structure, the DNA. And that, the CRISPR comes from the company's called CRISPR. They did some technology to make vegetables much crispier than they would have if they were straight from the field.
Is that true?
No, but it sounds really good.
I was like, I don't know.
No, but I think that's important. I mean, that's the holy grail, Jeremy. We know that
crispy vegetables, or
we know ViaCyte has had its issues with their encapsulation, but you said it from the very beginning. You did all the original studies that this kind of research isn't easy, and they learned quite a bit over the last 4 or 5 years, and now their technology is changing, and Vertex as well. So it's just not an easy fix, and I do think we're going to have multiple, quote unquote, if you want to call them failures, before we have some successes.
Yeah, we did the very first implant of a patient with these encapsulated, stem cells in 2014. And so literally, in the operating room doing this first in the world. And so now it's been 8 years, and it's not going as fast as anybody would like, but it is moving along.
Yeah, we should say thanks to Matt.
Yeah.
We'll keep his last name off the air for HIPAA compliance, but Matt was a volunteer, and his implants were not successful, but he contributed to the advancement of this technology.
Yeah. Maybe we should get him on here for a podcast.
Yeah. We should.
So I think, hopefully you guys are getting a sense of everything that's going on. And I think we should also highlight that this is all on the backdrop of all of our improvements in technology, CGM, artificial pancreas. So all these fields are kind of moving forward. That type 1 diabetes is a really exciting kind of area of research, which ultimately means there's developments happening every day. Here we are with new artificial pancreas systems. Omnipod 5 just getting approved the other day. Now we have maybe teplizumab potentially in August, all these cellular therapies. I mean, this stuff is happening now.
And that whole area that you're really the leader in, and I don't just say that, in adjunctive therapies. And the fact that, we have, medications that may attack some other areas of type 1, like the GRAs. Glucose receptor antagonists. You ready for that, folks? It's
Can you say it with a British accent, please?
I can't fake it like you do. Of course, yours was terrible.
Mine was really, really good.
We'll have to. Eric will do something to our voice with his magic that he does. We should probably just mention for the last time, where to get screened, which is the JDRF site.
Well, type 1 tested to get screened. And if you want to be in a clinical trial, honestly, just Google, find a clinical trial, JDRF. And then don't forget, we got a ton of stuff on our website, tcoad.org. Check out our video vault. Honestly, everything under the sun in terms of diabetes topics, I think we've covered. Have videos, have funny, songs of me and Steve in ridiculous outfits. So please check us out. And hope you guys are enjoying our podcast. If you like it, please comment, follow. I read all the comments like literally every day to see if like a new one's popped up, and no one's commented today, so I'm kind of sad. But anyways, thanks for doing this with me, Steve.
Jeremy, I learned a lot, and as always, and appreciate this topic is so important.
Yes. Take care, everybody.